for attending today's clinical meeting, either in person or virtually. You may listen today or at a future date. I'm Dr. Tambu, the chairperson for today. We have 5 different units presenting today. We begin with Dr. Keziah Philip from Medicine 3. Each presenter is given 10 minutes. At 8 minutes, there'll be a warning bell. So all the best to you.
Good morning, everyone. Today I'll be presenting Chubby Cheeks on behalf of Medicine 3. So we'll be discussing 2 cases. First case is Mrs. I, a 22-year-old female housewife from Walaja, who presented at 20 plus 3 weeks of gestation. She presented with complaints of fever for the past 3 days, parotid swelling for the past 6 days, bilateral days. History of presenting illness: her fever was low grade, associated with chills, subsiding with medications, no diurnal variations. It was also associated with swelling of the bilateral parotids with obliteration of the angle of mandible with tenderness. No warmth or erythema was noted. She also had complaints of diffuse, dull aching abdominal pain and non-bilious, non-blood tinged vomiting around 10 to 12 episodes per day for the past 2 days. She had initially sought treatment at a local hospital and was treated with IV antibiotics, and then was referred here for further management in view of non-subsiding of the symptoms. She gives history of exposure to mumps 2 weeks back, during which there were children in her neighborhood who had been diagnosed with mumps. There's no history of cough, breathing difficulty, loose stools, or rash or headache noted. Past history: no known comorbidities, and this is her first pregnancy. On examination, her BP was 110 by 80, heart rate was 108 beats per minute, temperature was 99, saturation was 100%, no pallor lymphadenopathy was noted, bilateral tender parotid swelling was present, no rash noted. Systemic examination was also normal. Going on to the next case, she is a 17-year-old female housewife from Lateri. She has presented with 34. She has presented at 34 plus 2 weeks of gestation, with history of fever for the past 3 days, right earache with right-sided cheek swelling for the 2 days, and cough for the past 3 days. History of presenting illness: fever was low grade without chills or rigors, subsiding with medications with no diurnal variation. She also had complaints of bilateral cheek swelling, right more than the left, with tenderness and right ear pain as well. No history of ear discharge or throat pain was noted. It was associated with dry cough. No complaints of breathing difficulty, headache, rash, vomiting, coryza. And she also had history of exposure to mumps present within the family itself. Her past history: she's a known case of acyanotic congenital heart disease, which was incidentally detected during her evaluation done as a routine basis for pregnancy. She was noted to have a small ASD with left to right shunt. On examination, her BP was 100 by 70, heart rate was 94 beats per minute, temperature was 99, saturation was 100%, no pallor, icterus, pedal edema, lymphadenopathy was noted. She also had bilateral tender parotid swelling, right more than the left. No rash was noted, throat was not congested. Systemic examination was normal. This is a picture taken of the patient with consent, which is showing right-sided parotid swelling. So to summarize, there were 2 pregnant ladies who presented with acute fever and cheek swelling. The differentials considered were mumps is the first differential considered in view of their history of exposure to the same illness. Other differentials that can be considered more in case of unilateral symptoms was acute bacterial suppurative parotitis, or even viral infections such as influenza, para-influenza, Epstein-Barr virus are also known to cause similar presentations. Going on to their investigations. A first female had hemoglobin of 10.7 with counts of 10,200 and differential counts, neutrophils of 62, lymphocytes of 28, creatinine of 0.44. All other investigations were normal except for amylase, which was noted to be severely elevated. Her anti-mumps IgM was found to be positive on further evaluation, and mumps IgG was found to be negative. The second case, the lady, she has a hemoglobin of 11.6 with a total counts of 17,100, with differential counts of 78, lymphocytes 15, creatinine 0.43. Electrolytes are normal. TSH was 1.957. Her IgM mumps antibodies are awaited as of now. So I would like to discuss in short about mumps in pregnancy. Mumps, as we all know, is a disease caused by a virus of the family Paramyxoviridae. It usually presents 8 to 25 days later after exposure to the virus, initially with features of coryza, upper respiratory tract illness, which is why it is highly contagious, followed by bilateral parotid swelling. And in a area where the disease is known to be endemic, the diagnosis is more or less clinical than laboratory. So how does mumps per se affect people in pregnancy? Now, this is a study that was done in long back, which was shown in 5 women who had volunteered to get the virus injected in them because they were planned for therapeutic abortions. So around 7 to 10 days before the scheduled abortion, they were given injections of this Gerald Lynn strain of the attenuated mumps virus, and then they underwent the scheduled abortion procedure. And it was found that the mumps was detected in around 2 to 5 placentas, but in none of the fetuses. But however, it is possible that the interval between the immunization and abortion was too short, which is why the viral replication was not found in the fetal organs. Other than that, itself, literature review has shown that per se, mumps is not closely related with any congenital anomalies. What it most commonly causes is it either causes premature births or abortion is what is more closely associated with mumps in pregnancy. This is a study that was done about what is the outcome of mothers who had mumps closer to the delivery. 3 women with symptomatic mumps during delivery had 3 different fatal outcomes. One infant was found to have swelling in the parotid area and was noted to have positive mumps skin test at 42 days of age. Second infant had developed pneumonia on day 7 and had to be hospitalized and intubated. That infant frequently presented with upper respiratory tract infection for the first 1 year of his life. The third infant, however, had no evidence of mumps and never developed any symptoms. In all 3 of these symptoms, infants reached normal developmental milestones and had no further complications. There was one more case report of mumps that had presented. A female infant was born at 40 weeks of gestation to a 30-year-old G6P5 female by spontaneous vaginal delivery. Maternal history was significant for exposure to mumps 2 weeks prior to the delivery. The baby was well until day 2, following which she started developing fever. Initial counts showed elevated counts with normal differentials. On day 4, the infant developed tachypnea cyanosis and was treated with oxygen. Initially, the chest radiograph findings were all normal, but because of progressive respiratory distress, she had to be intubated and began on mechanical ventilation on day 5. Eventually, the chest radiograph showed features of right upper lobe consolidation and diffuse patchy infiltrates. Blood gas was showing features of type 2 respiratory failure. Echocardiogram had showed increased pulmonary artery pressure and right ventricular enlargement consistent with pulmonary hypertension. Antibody titers at 4 weeks showed positive mumps IgG, which was positive initially also at birth also, but the IgM, which was initially negative, had turned positive at around 52 days of birth, which is consistent with recent infection. Eventually, the infant was tapered off oxygen and mechanical support and was discharged by day 60 of birth. Echocardiogram at the time of discharge also showed decreased right ventricular dilatation and resolution of the pulmonary hypertension. So, management of mumps per se. Diagnosis can be done either by viral swabs, which can be sent for RT-PCR, or anti-IgM and IgG antibodies in blood. Treatment, there is no specific antiviral therapy for treatment of mumps. Management includes supportive care and may include use of an analgesic or antipyretic agent, very similar to how it is usually treated in the general population. Parotid discomfort may be managed by application of warm or cold packs. Complication of mumps includes orchitis or ophritis and neurological manifestation, including meningitis, encephalitis, and deafness, and other less common complications. Prevention is vaccination in preconception area. Vaccine cannot be given in pregnancy. It's a live attenuated virus, which is contraindicated in pregnancy. If a patient has been vaccinated, it is advised to avoid pregnancy for the next 4 weeks. However, literature also shows that inadvertently immunized females do not develop severe complications and they can be just kept on follow-up. It's not per se an indication for MTP. Coming back to our patient, the first patient, she was admitted in the month of May. She's been followed up. No anomalies noted in the morphological scan of the first patient, and she's still continuing her pregnancy. The second patient is currently admitted with her, and both are yet to deliver. with that, come to the conclusion of our presentation. The learning points that I would like to present in this is that we need to keep a high index of suspicion, especially in endemic areas. Laboratory investigations are not per se indicated. Mostly it's a clinical diagnosis. And vaccines are to be avoided. Mumps per se has come down a lot in this era because of the vaccination that has been given, but still at times we do see an outbreak of mumps.
Do we have any data from India on pregnant women who had mumps and their maternal and fetal outcomes, or these are the only case reports you managed to find?
Yes, these are the only case reports. In fact, there are no case reports in the recent years. These are all mostly of early 2000s and late 1990s that we have found mostly the case reports and the discussion.
What is the vaccination history of these two women? Have they taken MMR vaccine in the past?
Yes, they have. They had, both of these women had taken MMR vaccination in the past. Even literature is also showing that in spite of having taken vaccination, there are still cases of people presenting with mumps. It's still under research. Why exactly, we don't know. Some say it could be an administrator defect, but sometimes it's been noted that they're still presenting with mumps.
Thank you, Keziah. Let's give Keziah a hand. Well done.